Welcome to the Saving Lives podcast. I'm Eddie Joe. Today, we're going to be discussing how certain calcium channel blockers create hypoxia and hypoxemia in ICU patients. Now, this is a podcast that I've been meaning to research for several years now because this is not something that I was ever taught during residency or medical school or anything like that. But I did start seeing it in my patients who were otherwise doing really well after cardiac surgery. Just to give you a quick little cardiac surgery case, me being in the intensive care unit as the intensivist, patient comes out the day before out of surgery, good, pre-op and post-op EF, slam dunk case, no big issues. The following day, you notice that the patient is on high flow nasal cannula or on non-invasive ventilation. And so you say to yourself, well, this patient had perfectly normal pulmonary function tests before surgery, and they didn't get an absurd amount of fluid. What in the world happened? And when you see enough of these cases, you start putting it together that there might be something with the antihypertensives that these patients are receiving, because a lot of them are just hypertensive. But before we get started, I have numerous citations for this podcast episode because, again, it took a significant amount of research. And you could check out those citations in the show notes down below. And as always, hat tip to the authors, and I do recommend you read these data for yourself. I always like to plug in my book, the Vasopressor and Inotrope Handbook. You can pick up a copy on either Amazon or my Shopify store. There is a coupon down below. But let's just talk about the problem first here. One of the things that a lot of people do not know is that calcium channel blockers can worsen oxygenation by shutting down the hypoxic pulmonary vasoconstriction, which an easy way to explain it is it's the lungs traffic control reflex that it diverts blood away from the poorly ventilated alveoli. If you take that reflex away, more blood flows through these low oxygen regions and they develop shunts, and it turns out that the PaO2 and the SpO2 fall. If you want to get a little bit more into the physiology of this hypoxic pulmonary vasoconstriction, which in the text it's shortened as HPV, but I cannot disassociate HPV from the sexually transmitted disease, so I'm actually going to keep on saying the hypoxic pulmonary vasoconstriction throughout this podcast episode. But this hypoxic pulmonary vasoconstriction, it depends on L-type calcium entry into the pulmonary arterial smooth muscle. When a patient has alveolar hypoxia, it depolarizes that muscle. Therefore, calcium comes in, it increases the tone, and the flow is throttled to the hypoxic units. The calcium channel blockers that I'm describing here as being the culprits are the dihydropyridine calcium channel blockers. And what they do is that they block those L-type channels. No calcium entry and therefore no vasoconstriction where it's needed. Blood just keeps on perfusing the poorly ventilated lung, VQ mismatch widens, and the AA gradient goes up. Now, this isn't theoretical. Classic experiments and early human studies with nifedipine showed that blocking those channels blunts the hypoxic pulmonary vasoconstriction response alongside measurable drops in the PaO2 under hypoxic conditions. And this is reflected in studies that were published in 1976, 1981, and 1982. So which agents are the culprits here? Well, the clinical signal is clearest with intravenous dihydropyridines used for acute hypertension. These include nicardipine, also called Cardine, and clevidipine, also called Clevoprex. There have been numerous reports that flag hypoxia with IV nicardipine and clevidipine. And that signal does not show up with oral nicardipine, just the IV, which tells you that the route and clinical context matter here. A recent case write-up described rapid hypoxemia after nicardipine that resolved with D-challenge. Exactly what we do in the hospital when we have these patients on a Cardine drip, for example. We turn it off and then they get better. Non-dihydropyridines are less clearly implicated in the literature set that I reviewed. So the bottom line is that treat any IV dihydropyridine as a potential contributor whenever the lung is relying on this hypoxic pulmonary vasoconstriction. Again, that's a mouthful. So who's at risk for this? Well, it turns out that it's in patients whose lungs are dependent on this hypoxic pulmonary vasoconstriction. This includes postoperative patients with basal atelectasis, i.e., everybody who goes through cardiac surgery and can't take a deep breath because they have chest tubes in place. This also takes place in obese patients who have dependent collapse. Data has also suggested that patients with pneumonia or focal ARDS also have this, as well as patients with COPD with regional hypoventilation. In a prospective cohort that I reviewed, atelectasis and obesity amplified the association between nicardipine and hypoxemia, which quite frankly matches the physiology perfectly. The more regional hypoxia you have, the more you need this hypoxic pulmonary vasoconstriction. And therefore, the more trouble you'll have if you pharmacologically blunt it. The other component is that you could expect the effect to show up early, often within the first hour of starting the medication or escalating the actual doses. So one could proactively monitor and react before it becomes a crisis. So what should we do to help these patients out? Well, first is treat the physiology as well as the exposure. If oxygenation drops after starting the IV Clevoprex or the IV nicardipine, consider the drug to be a suspect. Well, just turn the medication off. God has given us the ability to create numerous antihypertensives, so if they're having this reaction to those medications, well, pick something else. Some cases explain giving patients IV calcium, but the evidence that they reverse this calcium channel blocker related to hypoxemia is not consistent. There's also no data that we could keep the patient on the IV Cardine or the IV Clevoprex and just try to recruit the lung. There's no trial that says that doing these recruitment maneuvers will actually reverse this hypoxemia and make things better. So again, it's easier to just turn it off. So to wrap up this podcast episode, these intravenous dihydropyridine calcium channel blockers such as Clevoprex and Cardine can worsen oxygenation by disabling this hypoxic pulmonary vasoconstriction. This effect tends to show up early and it's most visible when the lung already relies on this hypoxic pulmonary vasoconstriction and often resolves quickly when you stop the medication and fix the lungs. Typically, when I see this taking place in a patient in the ICU, you turn off the medication and hopefully several hours later, it will resolve and the patient will just be on a nasal cannula as opposed to being on either high-flow nasal cannula or on non-invasive ventilation. Hope you guys enjoyed this podcast. Again, it was a lot of fun to do. This was, not just one article that I read in this case. It was a number of them. I think it was about 12 or so that I compiled. But I know this is not going to be the sexiest or the flashiest one, but for those of us who take care of patients in the cardiothoracic ICU, well, this is going to be quite relevant. Hope you have a great day. Bye.